Hi, this is Dr. Saima Hirji. I'm a specialist orthodontist in Kenya. Today, the topic of my presentation is side effects of orthodontic treatment, how to do risk management in orthodontics. There are two basic classifications of side effects, the dental effects and the general body effects of the orthodontic treatment. Regarding the dental effect, the orthodontic treatment may affect the tooth structures like enamel, pulp and root, gingiva and oral mucosa, periodontal ligament, alveolar bone, and TMJ. Orthodontic treatment also have a general body effects like pain and discomfort, allergic reactions, systemic effects, alteration in the diet, distortion in the speech, and exposure of radiation. On effects of enamels, there are various factors responsible for enamel damage during orthodontic treatment. In bonding visit, we start with the cleaning of the tooth with the pumice. This will also cause enamel loss. There is also enamel loss during the acid etching session. Decalcification and white spot lesions in cavities during orthodontic treatment can also end up in enamel loss. Debonding session and removal of the braces can produce fractures and cracks and damage the enamel. Mechanical removal process of the composite raising at the debonding visit also end up in losing enamel structure. Interproximal reduction to correct the shape of the tooth or to gain space to correct the malocclusion also produce enamel defect. During initial prophylaxis before placing the brackets on the teeth, the first step is to clean the teeth with a pumice or polishing paste with the use of either Bristol brush or rubber cup. Bristol brush removes 10 micrometer of the enamels and the rubber cup removes 5 micrometer of the enamel. During acid etching procedure, acids are used to etch or remove the surface enamel by dissolution of the mineral content. 30 to 50% of the phosphoric acid used for 15 to 60 seconds. It causes dissolution of either prism structure or boundaries. Micropores are created in the enamel, which are 10 to 50 micrometer in depth. To reduce the enamel damage during the acid procedure, we have an option of using malic acid or polyacrylic acid as an alternative to phosphoric acid. But the side effect of using these acids is result in a decreased bond strength. We can also use self-etching adhesive system to reduce the enamel damage while the bonding strength is optimal for braces treatment. White spot lesions. These lesions develop during the orthodontic treatment from decalcification of enamel surface. They range from 2 to 96% in orthodontic patient. These spots are a result of decrease in pH, which results in release of calcium and phosphate ion from the enamel. They are visible after 4 weeks of debonding. 10% reduction in the mineral content of the enamel found in the white spot lesions. It is considered as a precursor of caries lesion. There are 2 types of white spot lesions, the fast developing and the slow developing. How we can manage these white spot lesions in our practice? First, start with the prevention. If you don't want at all white spot lesion at the end of the treatment, we make sure that patient have a good oral hygiene. They use fluoride dentrifices and we use topical application of fluoride during orthodontic follow-up. We can also use fluoride-releasing adhesive system and auxiliaries like elastic ligature. Use of argon laser irrigation for composite curing has been shown to make enamel less susceptible to demineralization. Argon laser and fluoride treatment have synergetic effect on acid resistance. In case we found white spot lesion in our patients during the debonding visit, the protocol we use is we have to wait for 2 months after debonding to allow remineralization from the saliva. We avoid any topical placement of the fluoride at the debonding visit. If saliva capacity is not enough for remineralization, we can advise fluoride mouthwash and toothpaste. Frequent low doses of the topical fluoride, 1000 to 1500 ppm in a toothpaste are recommended rather than one-time large topical dose at the clinic. Patient can use 0.05% daily rinse of sodium fluoride or weekly rinse of 0.2% sodium fluoride at home. Surface abrasion of the tooth brushing and fluoride toothpaste will reduce the extent of white spot lesion. Acid or pumice microabrasion has been shown to improve the aesthetics of all stabilized lesions. Persistent white spot lesion can be managed by abrading with 18% hydrochloric acid in fine pumice in sequence of 30 seconds for a maximum of 10 times. After the last application, we apply fluoride varnish. Another side effect of the orthodontic treatment is enamel discoloration. It could be because of the enamel loss during the etching done at the bonding session, which affects the reflection of the light, or it could be because of the resin tag retained in the enamel after debonding. The extent of the enamel tags are 10 to 50 micrometer. These tags absorb the food color and corrosion products. Another side effect is the enamel wear from the ceramic braces. Ceramic braces cause wear of the enamel, especially maxillary incisor and canines are mostly affected. To avoid ceramic bracket placement in the mandibular anterior teeth in case of deep bite and minimal overjet. If we have to put lower braces made of ceramic, we advise to correct the deep bite and then we do the lower bonding with ceramic braces. Dental caries. The most common iatrogenic effect of the orthodontic treatment is dental caries. The component of the appliance and the bonding material promote plaque accumulation and bacterial colonization, especially Streptococcus mutans and Lactobacillus. Acid release causes remineralization and softening of the enamel with increased susceptibility to caries. The main causes of cavities during the braces treatment is visual obstruction by the appliance and malalignment teeth with plaque retention site. How we can predict our patient is susceptible to caries during orthodontic treatment. The hygiene of the patient is the first best indicator of patient caries risk. Any past caries exposure, failure to brush regularly with the fluoride toothpaste, regular consumption of sucrose between meal in form of snacks and the soft drink, all are the predictors of risk of cavities. Fixed orthodontic appliance induces a rapid increase in the volume of dental plaque. Also, the plaque in the orthodontic patient has much lower pH than on orthodontic patient. There is a rapid shift in the bacterial flora of the plaque following introduction of the orthodontic appliances. Change in the quality and the quantity of the plaque may end up in more cavity risk in orthodontic patient. What preventive measures we can take to make sure that our patients not suffer from the cavities during orthodontic treatment? We have to make sure that patient having a very good oral hygiene. Patient use fluoride dentifrices, mouthwashes and toothpastes. Patient should be given with fluoride supplementation. Fluoride releasing materials for orthodontic purposes like bonding material and elastic should be used in the clinic. An antibacterial agent like chlorhexidine mouthwashes should be advised to patient for regular use. Enamel damage with debonding. Debonding of the orthodontic attachment can lead to scratches, fractures, and cracking of the enamel. It also increases the risk of pulpal damage. Debonding force of greater than 13 megapascal may produce enamel fracture or tears, especially when the forces occur at an angle. Debonding strength ranging from 2.8 to 10 megapascal are adequate for clinical situation. The maximum bond strength should be less than cohesive strength of the enamel, which is 30 megapascal. This will allow for removal of the bracket without damaging the enamel surface. A bond in strength of less than 12.75 megapascal is considered safe for the enamel. Enamel cracks. These cracks are not visible on routine examination and photographs. They are only detected with a special trans-illumination technique. Prevalence of the crack after debonding has been found to be as high as 50%, of which vertical cracks are the most common. A clear correlation has been found between enamel crack and debonding forces. Higher the forces, the more cracks can be found in patient. Prevention of the enamel damage during debonding. This is only possible with the help of the using proper debonding technique. Optimal debonding force should not exceed 13 megapascal. Care should be taken when debonding from a compromised tooth. Adhesive material thickness should be very minimal during the bonding procedure. Debonding metal braces. We need to apply force that peel the bracket base away from the tooth. This causes bone failure at the adhesive bracket interface. Sharp edges of the plier apply a squeezing force at the enamel adhesive interface until the bracket fails. We can use a wine guard to squeeze the bracket wings. Debonding ceramic braces. Bond strength of ceramic braces depend on the type of the retention used for the bonding of the ceramic braces. If it's a chemical bonding, it is more stronger versus a mechanical bonding. The conditional material used, either the phosphoric acid or the polyacrylic acid, also matters. Polyacrylic acid produces weak bond and debonding is very easy. Bonding material use also impact the debonding of the ceramic brackets. Filled bonding material are more strong bond strength and produce difficult debonding of the ceramic braces. Bond failure at the bracket base interface is better than enamel adhesive interface. Increased bond strength lead to bond failure at the enamel adhesive interface. Proper debonding example include a use of sharp edge instrument help in saving the enamel fracture. Following other bonding technique can be used to debond ceramic braces. We can use mechanical debonding technique. We can use the burrs and sharp metal instrument to debond the ceramic braces. We can also use electrothermal debonding technique, ultrasonic debonding technique, or laser debonding technique to remove the ceramic braces without fracturing enamels. Effect on the dental pulp. Orthodontic forces produce cell damage, inflammatory changes, and circulatory disturbances. They stimulate the sensory nerves, which release the neuropeptides, and these neuropeptides can cause vasodilation and increase vascular permeability, which end up in neurogenic inflammation. Histologic studies shows that pulpal reaction to orthodontic forces can range from vascular stasis to pulpal necrosis. These responses are greater at the start of the treatment and gradually decrease. There are occasional report of loss of vitality with orthodontic forces. The predisposing factors which leads to loss of vitality includes previous history of trauma, poorly controlled orthodontic forces, uncontrolled tipping, movement of the root apex out of the alveolar bone in palatal and labial plate, degeneration of the odontoblastic layer occur after the intrusive and extrusive forces due to circulatory disturbance in the dental pulp. Animal studies have shown disruption of the odontoblastic layer after bodily movement and torquing forces. We recommend that to avoid the pulpal damage, we should use optimal force level for tooth movement. Avoid excessive forces during intrusion and torque. Avoid uncontrolled tipping. Careful mechanics should be used for teeth with history of trauma. Avoid round tipping and jiggling forces. External apical root resorption. It produces permanent shortening of the root apex, a common complication of the orthodontic treatment, mostly involve maxillary incisor. 1 to 2 millimeter is found in majority of the cases. 1 out of 20 of the orthodontic patient may end up having an external apical root resorption of up to 5 millimeters. In 7 to 13% non-orthodontic patients also have 1 to 3 millimeter of the root resorption. There are various reasons of the external apical root resorption, which include genetic predisposition, pre-existing inflammatory condition like periodontitis, systemic conditions like diabetes, asthma, or allergic reaction, local factors and habit like nail biting, previous history of trauma, dental anomalies, orthodontic mechanics, which include use of heavy elastics and forces and use of rectangular wires, movement of the tooth root into a cortical bone by uncontrolled tipping can also lead to the external apical root resorption. In this picture, you can see the patient is asthmatic and how much root resorption is noticed during the orthodontic treatment. This is a picture showing the root resorption after trauma. Here you can see the root resorption in the tooth having abnormal root morphology. We can measure the root resorption by using an index. Grade 1 is classified when there is an irregular root contour. Grade 2, when apical root resorption of less than 2 millimeter, it called as a minor resorption. Grade 3 is apical root resorption of 2 millimeter, from 2 millimeter to 1/3 of the original root length, called as a severe root resorption. And grade 4, it's called as extreme root resorption, where there is a greater than 1/3 of the original root length is resorbed. The another classification of root resorption is given by Prophet. He classified into 3 categories. Stage 1 is a slight blunting. Stage 2 is a moderate root resorption of up to 1/4 of the root length. And stage 3 is a severe root resorption greater than 1/4 of the root length. Management of the external apical root resorption. Pre-treatment, we have to evaluate our patient and rule out all the high-risk patients through history taking. Periodontal condition and pre-existing root resorption must be evaluated and registered for the patient. We can do the periapical radiograph for the patient having periodontitis. Assess the type and extent of the tooth movement, duration of the treatment, and the need of the extraction. In the patient with a severe risk, the individual plan need to be modified. Like we have to use light forces, we should have a limited goal, and a shorter duration of the treatment is recommended. During treatment, the patient with the external apical root resorption, we need to do the initial follow-up with the x-rays after 6 to 9 months. 2 periapical x-rays need to be taken from 2 different angulation. If no radiographic sign of external apical root resorption seen at this stage, the risk of the severe resorption at the end of the treatment is minimal. Minor resorption observed at the 6th month of the treatment, we need to take it as a risk of progressive root resorption at the end of the treatment. So such patient need to be monitored during the treatment. The risk can be reduced by temporary suspension of the treatment for 2 to 3 months by putting a passive arch wire. A further radiographic follow-up after every 3 months is recommended in this group. Post-treatment, full mouth radiographic examination need to be done to detect any root resorption in high-risk patient. In mild to moderate resorption, no further action is needed. In severe root resorption cases, especially when root length is less than crown length, there is a risk of increased mobility with time. Further follow-up and instruction to the patient is given and recommended. Literature shows that there is a correlation between the gender and root resorption. Female are more susceptible to root resorption than male. Literature also shows that some of the dental anomalies like atopia and agenesis of the teeth and have more tendency for root resorption during orthodontic treatment. Forces using jiggling of the teeth, intrusion, and torque increase the chances of the root resorption. Internal root resorption. EARR can occur as a sequence of orthodontic tooth movement. Multifactorial etiology includes individual susceptibility, genetics, and systematic effect. Pro-inflammatory cytokines are released as a result of orthodontic force, and this can cause internal root resorption. Teeth subjected to intrusive forces show more internal root resorption. Endodontic treated teeth show significantly less root resorption, internal root resorption, in comparison to the vital teeth. It shows that the role of the dental pulp is in the internal root resorption. Thank you so much.